So I think we can start, Yann. So welcome everybody, welcome to this webinar session. I am Mireille Chagang, I'm Capacity Strengthening Lead and Community Lead at Bluesquare, and feel free to reach me if you need any information regarding that webinar or other webinars organized by Bluesquare. So some words about Bluesquare for those who are not aware. So next slide. So Bluesquare is a Belgium-based company in global health, specialized in health information system, data science, and so on. Next slide. So we support governments and organizations to make smarter, timely, and better decisions through stronger data management. And we do this by designing, implementing, and supporting tailored information systems that integrate with a broader data ecosystem. So here you have different fields where we intervene. Health financing, geospatial information systems, monitoring and evaluation, logistic management, and also data science for health and data warehousing. So next slide. So we also develop and deploy in-house software tools. So here you will have DHIS2 suite. I think you all know DHIS2. We also have OpenExa, which is an integration, extraction, and analysis and visualization platform. We have Yazo, which is a georegistry tool, and we have OpenEMIS also, where we lead the architecture development of this tool. Next slide. So about our partners, we, as you see, we work with several actors across the globe. So we have global health funds, governments, NGO, and international agencies, and so on. Next slide. We carry our activities mainly in LMIS countries, so Western Africa, Central Africa, Eastern Africa, and Southern and America, and also Asia. Next slide, please. So this webinar is a framework of a series of webinars called Data in Practice, which aim at presenting proven approaches and tools for both information and of geospatial information systems and optimization of data to improve and strengthen health decision making. You will find on our YouTube channel more content about this series and about also other series we have in health financing and also in M&E, for example. Next slide. So the speakers of today are, first of all, Yann Forget, who is a geospatial data scientist at Bluesquare. At Bluesquare, his main role is to design and build data processing pipelines to make geography data more accessible to partners and clients. He's also involved in the maintenance and the development of health facility registry in several countries. Prior joining Bluesquare, Yann worked in the research field in population mapping, risk mapping, and also accessibility of healthcare as his topics. So Moritz Lehner will be the moderator of this session. Moritz is a geospatial data and health campaign digitization team lead at Bluesquare. He brings over 20 years of professional experience in applied and fundamental research and teaching in fields such as spatial information science and modeling, and also policy-related spatial analysis. So I will carry on with and I will give the micro to Moritz to present today's topic. Thank you, everybody.
Thank you, Mireille. Thank you for this introduction. So yes, today's webinar is about mapping accessibility to healthcare, which is obviously a very broad topic, and we will focus on a specific example in Niger, where we've been working on a tool for the Nigerian Ministry of Health, where we help them to kind of make sense of their data by identifying areas where, which are, let's say, the most optimal for placing new health facilities, or let's say upgrading health facilities. And so Yann will present the work on that tool, but also, let's say, the more global aspect of mapping accessibility to healthcare, and the questions that are linked to that, and then also go into some of the questions about more automated approaches. So just before we start, as Mireille just posted, please use the Q&A tool, which is at the bottom of the screen, to post your questions during the session. So Yann will speak about, let's say, about half an hour, and then we can discuss your questions after that. So over to Yann.
Thank you, Mireille. Thank you, Moritz. So yeah, hello everyone, and thank you for joining us today. And indeed, today I wanted to talk about mapping accessibility to healthcare, to explore the topic with you, and more specifically, how at Bluesquare we approach the problem, and how we try to provide solutions. But the goal is not only to showcase what we do at Bluesquare, it's also for you to leave this webinar with a better understanding of how healthcare accessibility mapping works, with more intuition regarding data you are using, and the general insights you can get from it, and more importantly, with more knowledge of how inaccuracies and quality issues in the data that you are using can impact your results and the decision-making process. So as a result, the webinar is going to be slightly technical, but I try to illustrate it as much as possible, and really don't hesitate to shoot your questions in the Q&A section of Zoom. Is there something that is not clear, or if you want us to dig deeper into a specific issue. So healthcare accessibility. Now, first, when we are talking about accessibility here during this webinar, we are actually talking about a specific aspect of accessibility, which is physical accessibility. So the physical distance from a service delivery point. So for example, a health facility, a health center, to the target user. So there is other types of accessibility: financial accessibility, cultural accessibility, social accessibility. But today we are only focusing on physical accessibility. So as Moritz said, it's a broad topic, but it's important. It impacts travel costs. So the cost in terms of time and money it's going to cost to the patient. But more importantly, it impacts healthcare seeking behavior. So whether a patient is going to seek healthcare when he needs it or not, depending on how far the health facility is. So here is the way we approach the problem of healthcare accessibility at Bluesquare, and this is also going to be the general structure of the webinar. So the third thing that we try to do is define the problem. So what is the question that we want to solve through accessibility mapping? Then we have to choose a metric. So we translate the problem into an actionable metric that we can actually use to make decisions. For example, percentage of people being covered by a specific health service in a district, things like that. Then we identify the input data set. So the quality of the data set that we have available, their shortcomings, and whether we can connect to them easily to build automated data pipelines. Then there is the spatial modeling process in itself. and finally the interpretation of the result and communicating around them. So to illustrate the whole process, we wanted to take the example of the carte sanitaire Niger project, which is funded by the Belgian Development Agency, ENABEL. So this is a project that started in 2019, collaboration with the Ministry of Health in Niger, and it consisted mainly on data collection campaigns to improve and collect missing data in the national health data system, so collect missing data on health facilities mainly. And then there is the whole process of valorizing this data through accessibility mapping. So we will use that example of the carte sanitaire Niger project through the webinar to illustrate the whole process of healthcare accessibility mapping from problem definition to results interpretation and software implementation. So first step, as I previously mentioned, is problem definition. And so most of the time in healthcare accessibility mapping, there is two types of objectives. The first one is an objective of monitoring. So monitor the states, the performance of health facility network by calculating statistics such as percentage of population being covered, percentage of population covered by each health facilities, identifying vulnerable areas, identifying overloaded facilities. And the other type of objective, it's an objective of optimization. So optimizing resource allocation, new investments in order to maximize a specific metric. So for example, to maximize here population coverage. So here, for example, it's going to be questions such as where to install new health facilities to maximize population coverage, and identify health facilities that could be upgraded to maximize again population coverage. So in the specific example of Niger, in the context of the carte sanitaire Niger project, there is two main types of health facilities in the context of this analysis: integrated health centers and the smaller ones, the health posts. And the questions that were interesting for the Ministry of Health were multiple, but mostly that was, what are the health posts that should be converted to health centers to maximize overall percentage of overall population coverage? And the second one was where to install potential new health centers in order to maximize population coverage. So now that the problem was defined, the Ministry of Health came up with a set of rules that are specific to the issue of healthcare accessibility in Niger. So the first one is okay, a population is considered as covered by a health center if it's located at less than 5 kilometers. So that's the first rule. The second one, that we don't want to install any new health center if it's located at less than 50 kilometers of an existing health center. And the last one is at least 5,000 new people must be served by a new health center for a new installation to be considered. So that was the specific set of rules that were chosen by the Ministry of Health for the specific issue of healthcare accessibility in Niger. So now that we have a problem defined, we have a set of rules defined, we still have to translate those problems into actionable metrics that we can calculate and with which we can take decisions. So here we have two questions. The first one is, what are health spots that should be converted to health centers? So it means, in other words, that we have for each health post to calculate the number of new people that would be covered if it was converted to a health center. The second one was to install new health centers to maximize population coverage. It means that we have to calculate for each point in space the amount of new people that will be covered if we install a new health center. So that's the two metrics that we want to compute and that we need. So to do that, we need data. We need mainly two types of data. First, we need data on the location of health facilities. So basically a geo-registry view for each health facility's location. So basically the coordinates and the type of the health facility. So whether it is a health center or a health post, for example. But we also need georeference data on population. So basically we need population maps. So in Niger, specifically, thanks to the work done in the context of the carte sanitaire project, we had an extensive georegistry, as you can see here with the health centers in green and the health posts in red. But of course, the quality of the data overall is going to be really important for your analysis. So basically here, if we are missing health facilities, if we are missing health center, or if we are missing health post, we are going to underestimate accessibility. So we are going to underestimate population coverage. Same thing if we have errors in the facility types or in the location of its facility. So the first step, that's why at Bluesquare I think that the first and the most important step in a good accessibility analysis is a well-maintained georegistry. It's the most important source of data. Then there is the question of population. We need geographic, geolocated population data. So here we have the results of a census from the National Statistics Office of Niger. And so for each data point, we have information about the location of the survey, basically. We have coordinate, we have longitude, we have latitude. So we can put each data point on a map. So now we have geographic information about health facilities and about population. So here, each red point that you can see, it's a data point in the population census. But if you don't have access to census data, there is alternative. You can use open access geographic datasets such as WorldPop, which are based on official national censuses, but distributed into a map, into a population map. So as a result, we have for each point in space an estimate of the population count, of the population number. Here, the more it's yellow, the higher the population is predicted to be. Plus, in WorldPop, you have the choice to choose between different types of products. You have the unconstrained dataset, the one I just showed you, and the constrained dataset, the one that you are seeing here. So in this dataset, the population is only distributed inside into the area where we detected built-up area, where we detected urban areas, because people are located in built-up in buildings. So it's a bit more accurate, provided that the urban detection process is also accurate and good. So same thing again that with health facilities, missing data will impact the results. So for population data here, if you are missing data points, you are going to overestimate accessibility and overestimate population coverage. So the issue is a bit bigger because you can potentially miss vulnerable population. If people are not on the map, you are going to miss them and not include them in the accessibility statistics. So it can be an issue. And that's why we think that the second step of good accessibility analysis is to have up-to-date and accurate, spatially accurate population maps. And so after all of that, there is a spatial modeling process in itself. And so now that we have all of the data, we define the problems, we define the metrics, the rules, the thresholds that we want to use. The problem is now quite simple. So here you can see 4 health centers and the 15 kilometers area around them and the 5 kilometers area. So in the 15 kilometers area, that's the area where we don't want to install new health centers. And in the 5 kilometers area, that's where the population is considered as covered by the health center. So again, depending on the type of population data that you use, you can get that the analysis is going to be a bit different. So here it's the WorldPop data, for example, and here it's data from population census. So if you remember the first problem that was expressed, it was, okay, what are health spots that should be converted that should be converted to health centers? The goal was to compute one metric, which was for each health post, the number of people covered if it was converted to health center. So as an example, you can see here 2 health posts between all of the health centers and the 5 kilometers area around them. So that would be the area where population would be considered as covered by the health post if it was converted to a health center. And so now we just have to count the population inside those 5 kilometers area to have that matrix of new people covered if it was converted to a health center. So if we do that for all of the health spots in the country, we already have solved the first problem. We already have that metric. And we can directly exclude from the analysis all of the health spots that are located inside the influence area of an existing health center. So basically that's the 15 kilometers area that you see here in light green. And the second problem is a bit more complex. So where to install new health centers to maximize population coverage? Because now you have to calculate for each point in space the number of people that would be covered if we would install a new health center. But with the data that we have, we can calculate that. So here you can see that for each point in space, we calculated the number of potential people covered. So the lighter it is here, the lighter the color is, the higher the number of people will be covered. But here we are not interested in specific areas. We are not interested in areas that are located at less than 15 kilometers of an existing health center, because we are only checking for area where we could install new health center. And so from there, we can identify potential areas for the installation of new health center, as you can see here in red. So in that specific case, it would be because of the presence of several small urban areas which are not currently served by existing health centers, and that are, most of them are outside even of the 15 kilometers area of existing health centers. So what this means is that if you install a new health center inside that red area, you could potentially increase population coverage by 6,000. So that's the main process in terms of spatial modeling. So we have the main metric that we need to take decisions. We have now a good understanding and a good intuition the data that we are using and the shortcomings of the data, the impact that it can have on the results, on the decisions that we can make or not, and in the end, the impact that it can have on the communities impacted by the decisions. Now we have the question of data integration and automation. Basically, what we wanted was to formalize and automate the process for the Ministry of Health by building a tool to automatically get data from the DHIS2, so from the National Health Data System to get location of health facilities, that type, and population data from WorldPop in order to run those models and those modeling processes in routine. So we built a tool to make the process a little bit easier. So I will try to demonstrate quickly how it can be used. I just have to switch the window I'm sharing. All right. So this is basically just a very simple graphical interface for what it's really a script and does a hood. So where you can just provide some information about the country. So here it's Niger because it has been developed for Niger. But more interestingly, you can put credential to your DHIS, for instance, to automatically connect to it and get location data for the health facilities. But of course, if you have some files that you want to use, you can also directly use them, directly upload them into the tool. You can provide information about the DHIS2 groups that correspond to health centers, that corresponds to health posts. You can provide a file with population census data, or if you don't have it, you can just use WorldPop data. So again, there is different types of WorldPop data. The tool allows you to choose what type of data you want to use. And then there is all of the rules that have been set by the Ministry of Health. In their specific case, it's a minimum distance of 15 kilometers between an existing health center and a new one. The population is going to be considered as covered by a health center if it's located at less than 5 kilometers, etc., etc. That type of rule. And so you just input those parameters and you can just start the analysis. So it takes a little bit of time, maybe 5-10 minutes for the whole extraction process to happen, but I already ran it before. So basically the output is a set of files that you can open in a GIS software such as QGIS, for example. And then you have access to all of the results of the analysis. So here we are in Niger. So for example, we have for each health post, the amount of people that would be covered, that would be newly covered if the health post was converted to an health center. So as you can see, there is specific health posts with quite high numbers. For example, here we have a specific health post with more than 10,000 people that would be newly covered if we would convert it to a health center. And indeed, as you can see, in its 5-kilometer area, there is some specific settlements with urban areas. So we can see them here. Here again in the locality with the specific health post. And so if we would install, if we would convert, sorry, that specific health post into an health center, it would mean that 11,000 more people would be covered by an health center. So as you can see here, there was also other health posts, but they have been excluded from the analysis because they are actually included in the area of influence of the existing health center. So they are not considered as a potential reconversion. So actually, this specific health post is kind of a bit of is quite near an existing health center. So maybe that would not be the best candidate for a reconversion, but you can still access more advanced statistics if you open the table. So it's in QGIS, but you could just open the file in Excel, for example. And so if in the file you have access to the number of people that will be covered by the health post if it was reconverted, and the distance to the nearest health center. So as you can see, there is specific health posts that are a lot more distant from an existing health center. For example, this one with a lot of potentially new people covered, and at 27 kilometers of an existing health center. It's here. So again, we indeed have some people living here, a specific urban area here that would be covered if we would implement, if you would convert that specific health post into an health center. So that's the kind of data that the analyst can provide. Same thing for extension areas. So here it's not the conversion of health posts, it's just general areas where if you would install a new health center, you would cover more than 5,000 people. So you have access to all of that information and you can explore it and interpret the results according to your knowledge of the territory. So to go back to the presentation, so we think that the whole process of using the georegistry, crossing the data of health facilities with population maps to obtain accessibility statistics, such as the one I just presented to you, is a really good process. And you can really get a good idea about the structure and the weaknesses of your health service network. But of course, in the end, what matters is not the distance in kilometers to the health facility. It's the time it takes to reach the health facility. And the time it takes is going to depend on a lot more data. So we will need data on transport network, on roads, on land cover, on rivers, on water bodies, lakes, on the topography, on the slope, etc., etc. And of course, as always, up-to-date data on the location of health facilities, the services they provide, population maps, again, in order to compute the travel times. So basically, it's a lot more data. It's a lot more complex. So you need to be able to select the data that you need, download it, process it, etc. And in the end, it's a bit more complex to interpret the result because there is a lot more shortcomings to take into account in the data that you are using. So what we are doing now at Bluesquare today is we are trying to develop a web application to do that. So this is going to be a web application based on the access mode tool. This is a project we are doing with the GIS Center of the World Health Organization, WHO. And so the objective for us is that users should be able to run that kind of analysis for their country without having to collect themselves the data and cover transport network, topography, population, etc. So the idea is to connect it directly to a set of open access geographic data sources such as OpenStreetMap, WorldPop, or other open access land cover maps, and also the possibility to connect directly to a DHIS2 instance in order to collect location of health facilities, filter them depending on the services they provide, etc., etc. But that kind of the next step in terms of accessibility modeling. So stay tuned if you are interested in the process, and don't hesitate to shoot questions in the QA in the QA section of Zoom if you need some more information, if you want some more information about a specific issue we talked about, or if you want us to dig deeper into a specific question. Thank you very much.
So thank you very much, Yann, for the presentation. I hope you all got a very good feeling now of what we have been working on in terms of accessibility to health, and especially trying to help ministries of health optimize their investments. So the floor is now open to questions from your side. There's one question already from Gervais, which is, does the tool recalculate the population covered by old health posts? So once you decide, okay, this health post is going to be a health center, is that taken into account by the tool?
No, because the tool is not taking into account the reconversion process, just support for decision making. So the tool is not going to consider that a specific health post is going to be reconverted just based on statistics and on metrics we computed. It's actually the role of the analyst, of the people that are working at the Ministry of Health, to interpret the result, interpret the metrics, interpret the statistics, to take decision based on that. So the tool is not going to do that now. Yeah.
Okay, so if any of you who ask questions are not happy with the answers, don't hesitate to post a follow-up. But I think that was sufficient here. So Beatrice is asking, how long did it take to develop this tool?
So, I mean, the work process of defining the objectives, organizing, defining what we really want with the Ministry of Health and during the meeting, etc. I think it takes something like 6 months in the end. Correct me if I'm wrong. But the actual development in itself, so the actual programming, coding, etc., it took something like less than a month of working in terms of pure software development.
Yeah, I think it's important to note here that obviously the biggest part of this kind of work is often not the actual development. It's more the analysis and the back and forth and trying to really clarify the needs and to see, okay, are the outputs all right in this format? Would you need them in another format? And all this. So I think that's often the much bigger part than the actual development. Yes.
Yeah, it's always the smallest question that takes a lot of time to discuss and to take decisions. For example, do we want to consider, how do we want to work with district borders, for example? Because in the end, people at Ministry of Health are going to take decisions at the scale of the districts. So they are going to consider health posts, reconversion, and the installation of new health centers at the scale of one district at the same time. So that kind of question are going to have an impact on development question. And in the end, they are more time consuming than the actual development. the tool.
Right, and Beatrice has a follow-up question, which is who has access to it? Is it the end users? And hopefully decentralized entities will be able to use it as a M&E tool. Maybe I can answer that actually. I mean, this is obviously part of the discussions with the ministry, and we are not the ones kind of who decide that. This is the ministry has to decide its own processes. We only provide the tool, obviously. But the idea here is that actually the results, I mean, the tool would probably be run more centrally, at least at the beginning, but the results of a run of the tool will then be sent to all the centralized agencies and probably made available in their visualization tool of the health map. So there is already a visualization tool of the health map in Niger. And so the next step now will be that the data coming out of this tool here will be then fed into that visualization, so that then people can actually visualize, okay, in my district, where are the areas where the tool tells me that I will reach the highest population numbers, and so that they can then use, let's say, a detailed knowledge that they have, local knowledge, in order to then make the most informed decision.
Yeah. In fact, there is two aspects on the question. There is the data and the tool in itself. So I think the idea is still to release the tool as an open source tool, but the data it's another issue. Yeah.
Yes, the tool is possibly available as an open source tool, and as Yann showed, you can use it in any context as long as you define the data you need and the area you need. That makes it available to everyone, but obviously it's not always. It's not because it's available to everyone that it's accessible to everyone. That poses questions of accessibility again. But yes, so it is available. Maybe I just go on to a question from someone else before we can come back to you, Beatrice. But Ibrahim had asked also a question if this is only for private or only for public, but also for private data. So just that you know, the data collection, there's different phases, if you want, in the data collection. There was a big the project that Yann spoke about starting in 2019, which kind of was a one-shot effort to really collect the data, where again, Bluesquare provided the data collection app, which is publicly available, and there's about, I think, over 2,000 different users actually uploaded data using that tool. So this is mostly people working at all the different levels of the health ministry across the country. And so now the data has been pushed now into where it's currently still, part of it's still being pushed into the HMIS of Niger. And at the same time, we've been working with the ministry to build up a system of a, let's say, continuous update of that data. And so it's kind of up to the Ministry of Health again to see then who is even included in that. At this stage, it is mostly all health centers which report to the HMIS, which is mostly the public, but some private health centers as well. And it's an ongoing process within the Ministry of Health to enhance that map, to include more and more parts into that. Again, the tool you can use with whatever data set you want. So you can, if you have a data set of private and public health centers together, you just load it into the tool and then you can run it. Yeah, I hope that answers the question. Then back to Beatrice's question, which is what are the prerequisites to envisage such a tool in a fragile country where access to health data and population are not straightforward? Well, I think, I mean, again, health data and population data are not straightforward in most countries. Also in Niger, it wasn't easy, and there's areas in Niger where accessibility is difficult because of security questions as well. And population data, the census is now being prepared in Niger, already knowing that probably there's not going to be access to all parts of the country in order to have population data. So this is obviously something which is beyond this tool. This reflects what Yann said at the very beginning, which is that the quality of the data you put in is very important in terms of the quality of what you get out. And the tool can obviously not create better data than the data that exists. There have been efforts now, for example, Burkina, where there's been a collaboration between the INSD and WorldPop to actually model the population in those areas which weren't accessible during the census. So this is some of the solutions that are there. There's a question from Paola asking, what's the difference between access mode and this tool? Is it a standalone tool or is it integrated into some platform? So it's actually two questions. Yann, do you want to take that?
Yeah, of course. So it is a standalone tool, but the main difference between access mode and you are still seeing my screen, right?
Yes.
So the main difference between access mode and this tool is the metrics that we are using. So in this tool, we are using accessibility in the concept of accessibility, of physical accessibility in terms of distance to an health facility. So we measure it in kilometers with very simple buffer areas. In access mode, we are using a method that is called cost distance analysis, and to actually compute metrics such as travel time. So we measure accessibility in time, in minutes, in hours. So it's different because we take into account the road network. Of course, the fact that we are moving a lot faster on roads and on specific land covers that if we have water bodies, if we have rivers, if we have a mountain, things like that. So this is the main difference. And of course, more generally, the main difference is complexity in terms of the whole analysis process, because with access mode, you need a lot more data: transport network, land cover, surface water, water bodies, rivers, topography, etc., etc. A lot more modeling parameters. And so the issues we were discussing just earlier about data quality, the trust you have in the data that you are using, they are even more important here because you have a lot more input data. It's a bit more complicated sometimes. The more data you use, the more complicated it is to keep track of all of the quality issues that you can have, all of the impacts that it can have on the results and on the metrics and on the decisions that you are taking ultimately. But yeah, okay. And of course, another difference is that the tool we presented today, it's a standalone tool, so basically a desktop application, and the application we are developing for access mode is going to be a web application, so basically a website.
Yeah, I think there's also a question of complexity of usage, that this tool that we developed here was tailored to the request of the Ministry of Health to really allow them to have a very simple tool to do this. Obviously, once, and also that at this stage, the access mode web application is not in production yet. It will be in a few months, I think, but not at this stage yet. So, and the Ministry of Health needed something right now. So I think this is always a compromise you need to find, obviously. There was also the remark from Beatrice about, let's say, the introduction of this tool with eHMIS and the possibility of having both systems talk to each other. So as Yann showed, there's already a very direct integration between DHIS2 and this tool, in the sense that you can just define your DHIS2 instance that you want to use and where you want to get your data from on your health facilities. That obviously implies that you do have information on geographic location of these health facilities in your HMIS, which is not the case in every country, but in Niger it is. So, and the idea is also that the data that is then out, I mean, the output of this tool can be quite easily pushed back into the HMIS in the sense that you can add that, for example, as a data element linked to the health facilities, to have the information for this health facility. What is the population that is covered in the 5 kilometer radius, for example? So this can then feed back into. Next question from Paula is, in the distance tool, is it possible to adjust target populations in the tool, e.g. reach at least 80% versus 100% or something like that?
So yeah, to adjust the targets in terms of population covered. So not really, because with that specific tool, what we are trying to do is to kind of output a short list of the best candidates for reconversion or the best areas to potentially install new health centers, but we are not simulating the actual reconversion and the actual installation of new health facilities, new health centers. So we don't have any iterative process where at each iteration we would install a new health center, convert a new health post until we reach a specific target population. So that's something we would let to that responsibility would let to the analyst based on the metrics that we compute for each area and for each health post that could be reconverted to health center. So the metric basically distance to the nearest health center, to the nearest existing health center, and the amount of population it would cover if it was converted. So no, we can't adjust that kind of target thresholds.
Then there's another question again from Beatrice: with any other country where this tool is fully operational and integrated?
So no, we didn't try to run the tool in any country. We developed it to work on any country because it's automatic. As long as you have population data for that specific country, or if you don't have it, you can just use the WorldPop data. As long as you have health facility data or DHIS2 credentials, it should work, but we didn't actually implement it in any other country.
And then the question from Ibrahim is: access mod open source?
So the existing desktop application access mode, yes, it's already open source. You can go on the access mode website. This is developed by University of Geneva. The solution is open source, and the web application we are developing today at Bluesquare is also going to be open source. So then there is still a difference between open source and free, because the actual web application is going to have a kind of a restricted access in the beginning. So there's that, because there's going to be a lot of cloud computing going on, so the access should be restricted, I think, in the beginning. But in the end, that's going to depend mainly on WHO and their strategy on that. So we don't know yet, but it's at least it's going to be open source.
So one of the elements which maybe differentiates as well as the access mode, especially the web application and the tool that we just showed, is that obviously the tool can be run completely locally. So as long as you have all the data that you need as input, it just runs locally on your computer. You don't need to have anything in the cloud. You don't need to have access to a cloud system. And often for some countries also, if putting data into the cloud is an issue, in terms of trusting putting data somewhere out there, this might be a solution as well. Obviously, the access mode desktop application allows to do that as well, but let's say maybe with a bit more complexity involved in terms of the data preparation and all that. But maybe as a closing question to Yann, so I mean, would you say that, you can just take this tool, run it, and then say, okay, here are the places that we need to install health centers, or how should governments use this tool?
I think that's the objective. It's to just run the tool and for a specific month, maybe run it, I don't know, every year or every month or every semester, I don't know, every quarter, and then you can just click on the output file and just directly explore the results. I mean, in the way you prefer. Maybe if you are an analyst with skills in GIS, you are going to prefer to use QGIS. Such here. But if you aren't, maybe you are going to use Excel to see directly that kind of table and just directly access the output statistics. So basically population covered per health post and distance to the existing, to the nearest existing health center. And
right,
of course, yeah, go on.
No, I was just about to say, obviously, then there's a lot of local realities that this tool cannot let's say measure, and so that's why this obviously is used as a decision help, but you can't just automate obviously the decision of where investment should go.
Yeah, specifically you can see here there is 2 health posts with a lot more people covered, more than 10,000. So that's higher than the threshold defined by Ministry of Health, which was 5,000. But you can see here that there is one that is actually at 15 kilometers of an existing health center, and one that have less population covered, but that is at 25 kilometers of an existing health center. So that kind of secondary statistics are going to be useful also to take decisions. So it's complicated to automate it in the end, and you still have to have also knowledge of your territory, of the communities, and the geographic landscape of the countries, of the country.
Okay, but I think we're at the end of our time. Thank you very much for attending. Don't hesitate to come back to us if you have any more questions. We're obviously available for speaking about this tool and the other tools that we work on. I give the floor back to Mireille for closing words.
Thank you. Although you said all, I will just add that tomorrow we have the French session, and we'll have the honor to have a representative of the Ministry of Health, the Direction of Statistics, which will present their perspective regarding building a carte sanitaire and mapping accessibility to healthcare. So yeah, so you can also share to your French-speaking colleagues. Thank you, everyone, and I wish you a good evening or good morning. Thank you.
Thank you, everyone. Bye-bye.